All right, Amanda and Steve, take it away.
Becky, before you go, would you talk to us about questions?
Q&A. Absolutely. Thank you for reminding me. So for those of you listening today to the webinar, we do have a Q&A portion. If you use your mouse and hover over the Q&A little folder icon on the bottom of your screen, you can ask questions via Q&A. We will not always answer questions throughout the presentation. We won't stop right in the middle of a sentence or anything like that. But as questions come to mind, go ahead, please, and type them in, and we will take them as we can. Thank you.
Thanks, Becky.
Thank you. So, hi, I'm Amanda Martin. I'm the Executive Director for the Center for Rural Health Innovation, which is a small nonprofit in Western North Carolina. And I run the Healthy Schools, School-Based Telemedicine program, which I'll tell you a little bit more about later.
And I'm Steve North, and I'm the Medical Director and founder of the Healthy Schools program, and am a practicing family physician and adolescent medicine specialist. I'm also the Medical Director for Telehealth for Mission Health System in Western North Carolina. So first and foremost, as in any good presentation, we need to put up a disclaimer. We don't represent HRSA, and nor do we represent the School-Based Health Alliance, although this presentation draws heavily on the grant that everybody's interested in, and also on the work of the School-Based Health Alliance. We also do not represent the American Telemedicine Association, or our opinions don't represent that. However, we're actively involved in writing the current pediatric telehealth guidelines, which should be released in May. So we are consultative partners with the Mid-Atlantic Telehealth Resource Center and have been consulting with multiple districts across the country for the past 4 or 5 years around development of school-based telehealth networks. And these are our own opinions, and they are really based on having been on our experiences providing school-based healthcare via telemedicine over the last 5 years.
So here we are. What we do want to talk about is using this opportunity to provide telemedicine into school-based health centers, and why that's a good idea. We're very excited about this because it is what we do. The picture that's on the screen on our slide is B-Log Elementary School, which is located in the upper corner of Yancey County. B-Log is a K-5 school with just under 60 students. That's 60. So most of the teachers teach more than one grade. The principal is also the 3rd grade teacher, and the 2nd grade teacher is also the librarian. So it's a very small school, and they have trouble really having all the resources they need. They're a great example of kids who have high need, high poverty, but it would be incredibly impractical to try to build a clinic there, a bricks and mortar school-based health center.
You're absolutely right. Trying to sustain a nurse practitioner at a school of 60 kids, I think people would be upset if we were doing well child checks on every child every week.
That would make it sustainable, though.
It could, yes. Yes.
Now, yeah. So our network, we call it Health eSchools. We think that's very clever, but it works for us. The Healthy Schools Network, you see our pretty map, and what we've got there is representing 4 counties. The bottom left corner is Asheville, and these are mountain counties spread out in the rural areas. Now, the furthest one from Asheville, from our big city, is only, 65, 70 miles to that furthest blue one, but it takes an hour and a half to get there. And some of the really close ones in green also take an hour and a half to get to from the big city, because you can't get there from here. There's this little mountain in between Asheville and the closest green dot called Mount Mitchell, which is the highest point this side of the Rockies, which we're very proud of, but it makes it hard to get places. So our program has been growing for these 5 years. We're in these 4 counties at 30 different schools, and those schools are across the board. We're at 2 community colleges that also have early college high school programs. We're at 4 high schools, 5 middle schools, and 19 elementary schools. So we're running the gamut of all of the kids in our communities. But you got to keep in mind, the green dots there represent a school district with just right at 2,000 kids in the entire school district.
And the purple dots are a county with a school system of about 1,800 kids. So we reach about 12,000 students total across the 30 schools, add in about another 1,000 faculty members and staff who we also see for acute medical issues.
And this is where rural comes in. Rural often means small. Okay, so that's about us. So let's dive into what's in this grant information and what we can do to help shed some light on it. So I'm sure everybody's been poring over this guy. I have my own copy. Steve has his own copy. Right on page 1, the first thing, the second paragraph of the entire document is about this Children's Health Insurance Program Reauthorization Act of 2009 and their definition of school-based health centers. We've summarized a couple of the points here. It's really important. This is what makes it a school-based health center and not just things happening in a school. So a school-based health center is located in or near. It's organized through, there are 3 things it's organized through, these relationships. To me, this is very important. It's not just the health providers and it's not just the school. It has to be the school and the community and the health providers in that community.
And what we do is we bring them all together in a community advisory board. So they meet quarterly and give us feedback on how we're doing. And in shaping a new program, this is of great benefit and can help you troubleshoot challenges with parents or scope of practice.
Another critical piece here is the administered by a sponsoring facility. And we're going to go back to that in a minute. Don't go yet.
Okay.
You're making me nervous with your finger on the button.
Sorry, I'll stop.
So I would draw your attention in the definition to the 4th point, which is provides through health professionals, primary health services. I have to read it to get it exactly right. So what this is talking about is the school-based health center is providing the primary health services through a provider, through a health provider. And so I would consider that very carefully if you're going to meet the definition of a school-based health center by using a teacher's aide or some other non-certified, non-licensed personnel, and just think about it. And then, of course, state requirements, we have to throw that in. Your state could say something different. So more on that sponsoring facility. There's a whole list of who qualifies as a sponsoring facility. They're here. Hopefully, whoever you are, whatever organization you're coming from, one of them will be the sponsoring facility. But they have a very specific role, which we're going to talk about a little bit more later. But in short, it's administrative, billing, and oversight.
And I think we need to emphasize that community health center is listed as the 3rd item. However, currently, under CMS policy, federally qualified health centers and rural health centers, so Section 330 programs, are not eligible to be distant sites for telehealth. Lots of bills in Congress surround that, but that is a barrier that you may want to...
For billing.
For billing. You can still provide the services all you want, completely legal and ethical, but billing may be an issue. So taking that into consideration is important. So the School-Based Health Alliance is an amazing group of folks, formerly known as the National Assembly on School-Based Health Centers, or School-Based Health Care, who have been around for 20 plus years. And school-based health centers have been around for 30 or more years, starting through Title 10 funding for reproductive health. And there's great data looking at how these work in bricks and mortar settings. However, it is still sort of a gray area about how we're going to successfully implement telehealth to match these kinds of outcomes. The core competencies developed by the School-Based Health Alliance are referenced, again, on page 1 of the grant. And we'd kind of like to dig into them because I think that in talking with the HRSA and others, this is an important part of what you're going to be developing. So the first issue is access. And I will not go into deep detail because this is a 6-page document with 7 or 8 bullet points under each header. But with access, the 2 things that stand out to me as important things to be considering is first, the issue of after-hours care. How are you as an entity providing that or connecting with local providers to do that, provide those services? And the second area is non-discrimination. they're the typical religion, color, creed tenets, but the most important one is regardless of ability to pay. Therefore, for uninsured kids, for students whose insurance company won't reimburse you for telehealth services, how are you going to get them seen and operate in a manner that lets everybody have access to everything that you have to offer?
Hey, Steve.
Yeah.
We do have a question, and if you want to hold this one till later, we certainly can come back to it. Actually, two questions, and it's around that FQHC, RHC billing issue.
Absolutely.
And
Yeah.
educating senators.
Yep. I see both of those questions from Ms. Mullins, and we'll tackle them in a little bit. This is an issue for National Rural Health Association as well.
Okay.
So the next core competency is being student-centered. And when you look at this core competency, item 2B matches almost directly with the health processes or disease processes that the HRSA grant asks you to specify how you're going to address. These include obesity, mental health, and in the core competencies, they talk about school failure, ADHD, exposure to violence and trauma. They talk about oral health as well as asthma, and that matches up very well. The next item is being school-focused. And so think about school-focused. Two keys here is a shared vision. This is not clinical services adjacent to a school. How are you integrated with the school as a whole so that you're working with administration and with teachers to identify kids with needs, bring them in for care, and then help them improve both their health outcomes and also their academic outcomes. And then the fourth item is being accountable. This is an interesting one to look at. They talk about areas of quality improvement, performance, and also satisfaction. So as you're designing a program and looking at the outcomes for the HRSA grant, how do you consider tools to measure patient, parent, and school system level satisfaction with the programs that you provide?
And over to me for a few more core competencies. And now, perhaps it goes without saying, but we went ahead and put the hyperlink on every single one of these slides to the core competencies on the School-Based Health Alliance website. They're all on one page, so you can get into these details yourself when it suits you. I want to talk about population level impact. This is not what you would think population health. It's not that kind of thing. It's more about the whole school population, and specifically reaching families, communicating with staff. It's providing screenings throughout the school as appropriate, not just to identify kids to come into the school-based health center, but also to identify needs that could be met elsewhere in the school. It's getting into the classrooms to provide health education as needed, as appropriate for that school. It could even be building level. Maybe it means that you move the smoking area further away from the school, or the equivalent now that nobody smokes at school anymore. The next is systems coordination. And now this means a couple of things. It's care coordination, so that we're working to reduce fragmentation of care, duplication of services and testing. It's also talking about your care partners, like access for after hours or for care that's out of the scope that you can provide. And this is super important when you're talking about telemedicine, because there's always going to be that question of, well, what if it's something you can't treat by telemedicine? Do you remember when we got that parent question from one of the elementary schools where the parent was very concerned about what we would do by telemedicine, over the computer for that kid who, if their child fell off the monkey bars and broke their arm?
And that's not our place. As the medical director, I'll say pretty clearly, that's where the school's emergency protocols take precedent. That child needs an x-ray, and that's not a service that we provide. I think that the systems coordination part, though, also goes to making sure that when I see a patient via telemedicine, and I do a lot of behavioral health work as an adolescent medicine doc, that I get those records back to the primary care physician. And I do that in a timely manner. We shoot for 48 hours. I don't get there all the time, but that is an admirable goal.
It is a very admirable goal, Steve. Moving on. sound business practices. This is the part that nobody wants to talk about, but the business case has to be strong. There ought to be a mechanism for billing as much as possible. Oh, wait, this is the sponsoring facility. This is going back to what I was saying before. Sponsoring facility provides the administrative arm. So maybe that's your medical supervision, your billing services, but it's also the ability to analyze your financial standing and say, how are we doing this year versus last year? The idea being that your school-based health center shouldn't get just sucked up into a much bigger entity where you can't draw a line around it and see how it's doing. And then the goal is also sustainability, financial sustainability that's not eternally grant funded. And don't we all dream of that day?
I've heard it exists.
It could happen, and certainly having a plan and the encouragement to have a plan for diverse resources to sustain longer term. So those are the core competencies from School-Based Health Alliance. So if you're scratching your head going, I don't know what a school-based health center is, now you do.
Yep. All right. As we think about this grant, and this is really in our perspective, there are things that aren't going to be viewed or scored as highly. And one of the first things is, well, who can apply? This is not about for-profit companies offering sort of fee-for-service care in the schools. That doesn't fit here. And then it's also not about a freestanding kiosk in the school. Austin, Minnesota has placed 2 of the Health Spot kiosks in some schools there for teachers and their families. And while that's a great service, and I think that there's a place for it, there's a much deeper level of integration that this grant is looking for. Finally, additionally, sideline sports medicine. People talk about that a lot. We're working to partner with our local sports medicine providers for our schools, but within the context of the services that we already provide. Sure, maybe you can take a portable unit out to the sidelines to do concussion screenings and use that same unit later in the week to see how that child is progressing in combination with a sports medicine doc or a neurologist. However, that child needs to be enrolled in your school-based health center. And you probably need to be looking at things more than just that concussion, but their overall health.
And also, not every student plays sports. This may be a shock to some families, but that wouldn't hit the equitability if the whole program is based on sidelines.
Yep. And then IEP services. There's great evidence that speech therapy can be delivered through telemedicine or telehealth. We did it for a year in one of our programs to help out a school district. However, if that's not in collaboration with the school-based health center, it's really not meeting the goals of this grant. And our interpretation is you will not be scored as well. And finally, there's the bus. And lots of people like the bus because it drives down the highway and you see Tooth Bus written on the side or your entity's logo. However, that is a mobile unit and has intermittent care, and even with some of the best integration, it doesn't reach where this grant is headed. So, we've got 5 years in on doing this, and we've learned a whole lot through failures and successes.
Both,
and I'm sorry, challenges and opportunities.
Yes, that.
But one of the big things that we know is that the equipment doesn't run itself. And we often hear from schools, our own schools included, well, we don't have a nurse full-time. B-Log Elementary School that we showed you earlier, Yancey County has 5 full-time school nurses and 9 schools. So B-Log has a school nurse every Wednesday morning. And kids aren't sick only on Wednesday mornings at B-Log. Yes, that does change our utilization patterns at B-Log compared to one of our larger high schools where there's 700 kids and that nurse who's at B-Log a half day is there 4.5 days. However, the grant talks about in that first line or in the opening CHRPA definition that this is a licensed health professional. And so it's going to be up to you to really decide, is that the presenter? It's definitely the provider on the distant end, but does your presenter need to be a licensed professional? And then you can extend that a little bit. So what is a licensed professional? So out at B-Log, the school secretary is also a certified medical assistant. So she's a licensed health provider. She has presented 1 or 2 patients over the last 4 years. And from my perspective, I'm not sure if her license is actually helping that much. but can you use a first responder? Can you use an EMT who's in the school? In rural communities, we're going to need to look beyond just using the school nurse, but also making sure that you're sort of true to the spirit. As from a school system perspective, the schools really prefer that the school nurses are doing the presentations.
That's been our experience.
Yeah. Yep.
So the next thing we put on lessons learned is that scheduling is very different than a regular practice. I have a background in family practice and managing that, and it's pretty straightforward. People call for an appointment, you have an open slot, you put them in. I will tell you this is very different. Now, I'm hoping that a lot of people listening today are already doing telehealth, so you know that there's a couple other components. You might need to obligate time, you might need to reserve a virtual room, that sort of thing. But in the school-based setting, you're also accounting for a school nurse who might only be there half the day or might only be here till 11, or she is subject to having to run over to another school. But you're also trying to get your primary care provider or your specialist all connected in. And now finally, let's go back to the one big thing at school. We're working around school schedules. A big part of what we're trying to do is keep kids at school. They're not meant to miss the whole day. So if you're going to be efficient, you might need to accommodate math class that starts at 9:12 and runs until 10:42. So really they can't be there till 10:50, without missing math. And if you've got high achieving kids in your high school, they don't want to miss math, or whatever their critical class is. So it's not super straightforward.
And while those of us sort of running a network and who've been working around schools understand that, it is a challenge when trying to work with a specialist or a pediatric cardiologist who is able to provide a half day a week to help them understand that there needs to be a little flexibility on their end, because what we're trying to do is save the kid the drive from Mitchell County, an hour down to Asheville for a 30-minute appointment, and then an hour back, and missing an entire day of school in our community. So that's one of those relationship pieces that you need to develop over time. Then there's HIPAA and FERPA. And most of us are healthcare providers. Some are probably in the school district end. FERPA could be seen as a parallel to HIPAA from an educational perspective. I, as a physician, can't just call up the principal and say, hey, how's Johnny doing in algebra? Although actually I feel it's a fairly important indicator, and I know it's an important indicator of his overall health, especially when you're looking at mental health issues. On the flip side, when the first grade teacher says, Mr. Jones, says, Mr. Jones, I need to send your son to be seen via telehealth because he has pink eye, and our great family nurse practitioner, Tanya Hensley, says, you know what? This is allergic conjunctivitis. He can go back to class, and they can look almost identical. Without that HIPAA-FERPA understanding and a memorandum of understanding that the parent has signed allowing that communication, it can be interpreted that she's not able to tell the classroom teacher that this is allergic conjunctivitis and the patient should be allowed to come back to class.
Not contagious.
Yeah, yeah.
So the next two kind of go together. I would reiterate 5 years of learning in this since we started in our first handful of schools, and it grew over the years, adding some each year. The growth curve for visits was really slow. We were very ambitious and hoped to see a whole lot more patients than we did. And I don't think it's because we weren't providing a good service. I really think it's just because change happens really slowly. And we were changing not only the place of care, because the school was a new place for people to receive health care, but also changing the delivery method. And we got a lot of questions about, how does that work and how is that secure, and you're going to record it? All of the usual pushbacks to telemedicine. We don't record our visits, by the way. That slipped out, but we don't record them. But people need to know that to feel comfortable with it. And it's really taken a word of mouth, slow approach. We can only send home so many flyers in the backpack. But people just aren't going to use it until they're comfortable with it, or they talk to somebody who has used it, and then they feel okay about it.
And I think that one of the really important parts of our success is having someone in the district. So we cover an area about the size of Rhode Island, and our program directors are essential to the success of our everyday operations. They do our promotions. They build relationships with the school nurses who serve as our presenters. We know that the more Christy Lewis, our great program director in McDowell County, goes out to the schools and meets with the nurses, those schools are going to have more visits. If she goes and sees Greta, we're going to see a little uptick in Greta's visits over the next 2 weeks because Christy brought her a coffee from Starbucks in town, which she can't get in Old Fort. Or Christy helped her, think through, well, yeah, that was a suitable patient. And it is really important that you account for this in how you engage. So one of the great roles that our program directors play is trying to coordinate these schedules. They handle our scheduling, they handle the billing. So how does a parent contact you and say, my kid needs to be seen? Mm-hmm. And what kind of secure communication do you use, whether it be email or a phone? Probably not going to post it on your Facebook page that Johnny needs a visit this afternoon. But those are the people that you need to engage, and they are your champions at the local level.
Right, and we absolutely could not have accomplished what we have without our boots on the ground. And it, everybody's going to have to decide for themselves, but our strong recommendation is that this is not an add-on to someone who's already overwhelmed with work, because my program directors have between 8 and 14 schools each, and they are very seldom in the office. They are out at those schools. They're at PTO meetings and staff meetings and hand-holding.
Put mileage in your budget for these folks, because if you're in a rural community, you are going to go through your mileage budget incredibly fast.
In the first 4 months of the fiscal year, maybe?
I don't know what you mean. So, yeah, that is an important thing to consider. And then let's talk about data for a little bit. One of the first things people want to talk about is numbers and utilization numbers. So in our first year of operation at 3 schools, we saw 20 kids maybe? 24, I'm sorry, very small numbers. Lots of issues around school nurse acceptance. And last year, when we were in 24 schools, we saw about 350 patients total. 85% of those returned to class or work that day. And still, not phenomenal numbers. However, when you look at a regular clinic or when you look at a bricks and mortar school-based health center, and to put this in perspective, Dallas Children's health system has the largest school-based telemedicine program in the nation, and they have currently 57 sites. They saw 450 kids in the 2014-2015 school year. So it's difficult to accommodate that. This year, we saw 350 last year. We're at the end of January, and January is a rough year for us because a couple of our districts were closed for literally 2 weeks due to snow. We have exceeded 350 visits, and most of those are coming at sites where we've been for more than 1 year. So it's this comfort level and it's this growth. So as you think about utilization, you can't compare to bricks and mortar school-based health centers. The reason being, my experience with bricks and mortar school-based health centers, and I trained in some in Rochester, New York, and helped lead a couple at some now closed schools in rural North Carolina, is that we count every contact with a kid. That kid comes in for a cough drop, that's a visit. But that's not possible virtually. So the school nurse is appropriately so serving as a gatekeeper or as doing some screening work. They may screen a little bit too much at times. You'd love to get that viral URI visit on a regular basis, but that makes it difficult to compare numbers. However, there's some real good outcome numbers from bricks and mortar school-based health centers. And we're going to provide a resource to a bibliography at the end of the presentation that you can find all these articles. But school-based health centers have been proven to improve access for adolescent mental health. They've been shown to improve asthma outcomes and decrease utilization from the health perspective. Additionally, on a school side, which is really the sweet part, like how can improving health impact academics? They increase student engagement in school and the students feel more connected. They also improve attendance, and in high-risk students, improve graduation rates. So as we think about, Oh, and if you're looking for an article to look at the a review of the telemedicine data out there for schools, there was one published last year in the Journal of School Nursing. And it says, well, the jury's still out, basically. So as you're thinking about the outcomes that you want to use in your group, as you're putting this proposal together, one of the first things is, what are you going to track? And first, I want you to look at operations. Did you get the sites launched that you'd say you would launch? Because that in and of itself can be a fairly difficult challenge.
I have to tell you, we had equipment delivered to a school, and we weren't getting any visits and no visits and no visits, and I went over there to check on it. This was early days. It wasn't plugged in.
Yeah. So
maybe that site wasn't really launched.
Right.
I'm just saying.
Right. And by the way, technically, the switch of a firewall on the school district level can shut down your program for days while you try to figure out that port. But that's another conversation. So and then look at the number of students that are enrolled. So whose parents have completed the packet in advance saying you can see my kids, and how many of those are in your electronic health record, and how does that number grow? Also, I would look at the number of contacts you have in general. So out in the community, if you're not going to see 100 visits in your first year of operation because you only have three sites, where are you getting the word out, and how are you getting the word out and building that community momentum? And then their health outcomes. Straightforward visit numbers is great. Billing is another great measure. But what about health indicators and subsequent follow-ups? So we're watching blood pressure and BMI pretty closely. And how are you doing that? And do you get that kid back in with their primary care physician or with your network to ensure that they are being seen? When you have a child with somewhere greater than stage 2 hypertension, are you able to get that student in to see a specialist as needed? Whether it be virtually or not, do you have that coordination of care? And then risk screening. So there's physical health risk screenings, BMI, blood pressure being two great ways to do that, but also behavioral health screening. So are you using a tool such as the PHQ-9 or PHQ Adolescent, or the GAPS, or some other more specific tool for your program? We use a program called RAPS, R-A-A-P-S. You can Google it. It's out of the University of Michigan. Jennifer Salerno developed it, well validated, and it is online, which is great for telehealth. And then finally, what about academic outcomes? Because it's really hard for me to control for the fact that a student missed 2 weeks of class during the hardest part of algebra due to a broken leg. However, what about looking at return to class data? Longitudinally, you may be able to look at visit frequency and overall absences or a change in their academic progress, but that's a really hard measure in year 1 or year 2, and the data sharing with districts can be very difficult around this based on state level policies.
But what we can count is what's written here, the return to class after a visit, as opposed to being sent home, keeping in mind that 100% of those kids would have left school if they had to go be seen down the street.
Yep.
So the other thing that we wanted to talk about a little bit is extended hours coverage. And this is in a couple of different areas. One is the connection to local providers. So in a couple of ways. It's super important to get your note back, as Steve mentioned. We try to be prompt with that, to get your note back to the identified PCP for that student, or to whoever referred them into your network. If they don't have a PCP, somebody probably is involved. And then there's also the angle of who are your patients going to call at 6 p.m. when school's closed, school nurse has gone home for the evening, and the antibiotic that you started them on is causing a rash.
Or didn't get to the pharmacy.
If it didn't show up and they're going, but I was going to start it tonight. So there needs to be a plan for that. And now some of you are going to come from organizations where you have a 24-hour line that people can call, and that's terrific, and I wish we had that. You may have the answer to your question. But if you don't have a ready answer for that, work on it, because that's very, very critical to school-based health centers. And then the other question that comes up is serving the broader school community. So are we talking about serving kids from the school in an after hours kind of arrangement, which if that's the case, then again, who's your presenter? Is it the school nurse working extra? Or are we talking about serving people in the community who are not students at the school? So are we talking about serving grandpa who lives next door? Are we talking about serving people who live near a school? Because in a lot of rural areas, the school is the focal point of the community. So if you're setting that up as a clinic, you get into all kinds of interesting things about sharing school nurse time to do non-school work. You also get into the question of who's allowed on the school campus. And does your school really want to open their doors to whoever has an appointment this afternoon? And those are big challenges that we don't have good answers for, but they certainly are something to consider before you say, oh yeah, we're going to see everybody and we're going to stay open until 5. That may not be as obvious as you think. So I feel like we've
talked for a while.
Yeah.
Yeah. And so we've got some questions, and we're going to start and take them, and we'll answer them live. So please keep them coming. So the first question from Susan Mullins, she asks about the billing issue in FQHCs and RHCs. And then Randy McKinney also asked, he said that in their state, and I'm not sure what state that is, per Medicaid guidelines provided for all-inclusive encounter rate payment for services provided by rural health clinics through telehealth infrastructure, so you can use it there. So we are not an FQHC, nor are we a rural health center. And this is an issue that comes up a lot in discussions, broader than just school-based telemedicine. And I cannot pull up the citation, but there's a report on the state of rural health from the NRHA, and I can get that out to people. It's buried somewhere on my computer that talks about this rural health issue and federally qualified health center issue. Now, I know of federally qualified health centers that are using telehealth from site to site, and that's one of the questions that is unclear. So if other people have more specific information, that would be great. It is just in our experience that when you bring up doing telehealth in a rural health center, you are not able to bill for that, or in a federally qualified health center.
I guess arguably the reason being that if they're already sort of hurting for provider time, they don't want to then share the provider time outside of that community.
It's unclear,
something like that,
to me, what the logic is.
Okay.
And so to go back to Ms. Mullins' questions, the National Rural Health Association is advocating for this. There have been multiple bills around telehealth in the federal legislative process over the past year. The current one is the Connect bill, and that directly addresses the site of service for primary care.
So I would just remind anyone who didn't join exactly at 2 o'clock, you may not have gotten the instructions. If you would like to ask a question, would you please type it into the Q&A option on your screen, and those will pop up for us to read. I don't think you all can see the questions as they're written, but we get to see them and we can answer them. While we're waiting for your questions to be typed in, one of the other things that I would mention is if you weren't there yesterday, by all means, go to the HRSA website and listen to the technical assistance webinar that happened yesterday. It should be posted by now. I haven't checked, but they said 24 hours and it was yesterday. So you should be able to listen to that and get a lot of details exactly about the grant, because as you can tell, we have not addressed specifics about the grant.
And this is Becky Sanders. I just wanted to let you know, everyone that is registered, we have captured your email address, so we can send Steve, if you can share your that NRHA billing information that you were talking about. We can share that with everyone who has registered for the call.
Terrific, thank you.
So we're having a fire alarm here at the hospital, so we'll continue to talk over that, I hope. They haven't announced what's going on exactly. But
I would love to answer the question that just popped up. Becky, are you able to hear us okay over the...
Yeah, can you speak up just as much as you can?
Sorry, let me bring the mic up right here. So the question is suggestions for creating positive community partnership with the school nurses. And the question goes on to ask if our school nurses are on our advisory committee. Thank you, Martha, for that question. I would say absolutely bring your school nurses in on the conversation very early. One of the concerns that was expressed in our program early on was that we were trying to replace the school nurses with a computer and take their jobs. And this was a very scary thing for some of our nurses, and it was absolutely not what we were doing. In fact, we would rather have more school nurses than less.
And our school nurses now view us as a tool that they use to help meet the health needs of the students who are there, as opposed to a threat. The National Association on School Nurses has a really nice infographic about the overlap between school-based health centers and school nurses. School nurses falling more on the public health and school-based health centers falling more towards the individual health end. However, it's a spectrum of care.
So as for the school nurses being on the advisory committee, in each of our communities, we have at least one school nurse, and quite often it's the lead school nurse. Depends on how yours is organized. They're certainly not prevented from participating. And because the school nurses are so critical to the success, there's somebody we're in contact with all the time. We make a point of getting them together as a group for a luncheon or a coffee or something like that a couple times a year to solicit their feedback and to keep those relationships as good as we can keep them.
So next question that we have is from Mark Boyd, and he asks, do you have any advice for providing behavioral health care services such as ADHD or disruptive behavior to schools via telehealth under this grant? Absolutely, but I think that is a large part of what I do in conjunction with our schools and with primarily behavioral health specialists who are seeing the kids in person in the schools, although we're working on expanding the care to telehealth. So the keys here, I think, are screening and then a referral process. So as you think about establishing your school-based health center, how do you work with administration to trigger a referral based on a discipline referral, a suspension, or a set number of absences? And then how do you work to get feedback on whether what you've done is working? So this is the HIPAA-FERPA moray that you need to sort of go into. But I think that there are a lot of ways to use telehealth to deliver behavioral health services. There's great evidence on it. And then partnering around the medication management, et cetera, is great.
So the medication management, this is where we get into paper scripts.
This is a huge challenge. So in North Carolina, I'm not able to send a Vyvanse or an ADHD medication prescription electronically without spending more money on my health record, on our EHR, and having the pharmacy have the technology to receive it. So we are still in the process of hand delivering prescriptions. I was on my way to Williamsburg on Wednesday afternoon, and the kids and I stopped by a pharmacy to drop off a prescription for a patient in an adjacent county. So
you may find that those boots on the ground program directors are very helpful for that. But that's part of thinking it through. I hope that answers your question. The next question is a little bit housekeeping, but yes, this webinar is being recorded and it will be made available in a few days, possibly the 1st of next week, on the National TRC, the National Telehealth Resource Center's YouTube channel.
So here's the web link. Becky's jumping in.
Yeah, I was just going to say, with all of these two questions that are kind of housekeeping related right now, we will be able to send out a link to that YouTube page when the recording is ready. We can send out the slides if you guys are okay with sharing your slides.
Sure.
And I don't have the TNGP grant notice in front of me. Amanda, do you have it to answer the question about that recording? If they download the guidance, it's in the guidance.
I'm not sure where they said it was going to be, but right on the front page of the funding opportunity announcement is Carlos Mina's contact information. And he said email him with any questions yesterday on that webinar many times. So
yeah, a couple pages into the guidance, it's got the information for that call, and then right underneath of that, it's listed exactly where that recording is going to be available.
It does.
Great.
Yep.
So it may not be up yet, but they were indicating they thought 24 hours from the time of the webinar, which is about now. So we might just be a little premature.
Oh, and Martha Bergen has done a great job of Googling and sharing links with us. I don't know if everybody else sees the Q&A.
So we'll send this. We'll send
Yeah,
that.
I can download that in the stuff that I send to Kathy, and we can share those.
Great.
Wonderful. Thank you.
Great.
So what other questions can we answer for you? I'm really hoping that our experience with school-based telehealth can give you all at least an example to start from, and certainly we're available to answer further questions.
Yep.
And there are the critical ways to reach us: email, and we'd be happy to do what we can to answer more questions.
Try to reply to everybody who sends us a question, and if you don't hear back from us in 48 hours, please email again.
Yeah.
We're already getting a fair number of questions about this, so we're willing to help out however we can, and with the concept that our time's a little limited with other projects. Yeah.
What do you think, Becky?
Last call for questions. We'll give it just another minute or so.
Sounds great.
Steve and Amanda, I want to thank you so much. You've provided a great deal of information, and I know there's a lot of interest in this particular grant. So.
Great. Thank you. Yeah, we're happy to do it.
Mm-hmm. And, you know, even before this grant came out, and even before we heard rumblings through the Telehealth Resource Center community that it was going to come out and be focused on school-based healthcare, uptake and questions in every TRC has come around this topic.
Yes, we have been given some talks. We were in Kansas City in August, and we had been in Jackson, Mississippi for the South Central TRC meeting last year about this time. Absolutely. So if you are a member of the School-Based Health Alliance, I'll make a plug now. There is a affinity group for folks doing telemedicine and interested in telemedicine, and you can find that through the School-Based Health Alliance website, which is here, sbhaforall.org. All right.
Okay, well, thank you very much. And like we said, we'll send out an email when the recording is available with the link to that.
Great.
Great.
Thank you so much.
Thank you,
Becky.
guys.